Today, we will talk about cystic fibrosis and machine learning, a topic that the lab, as well as the Center for AI Medicine, has been working at quite frequently and quite a lot. And I'm very happy to have a large panel today discussing this topic. And with Mihaela and Andres, two experts, who will tell us about cystic fibrosis and machine learning, respectively. So first of all, for those of you who are new to our sessions, Revolutionizing Healthcare is basically built as a shared community to develop a common language between the clinicians and the machine learners on either side of the divide, just to get those two together to really transform healthcare in the future. Our last sessions were on clinical trials. You can find them online on the Schaar Lab website, where we have all previous Revolutionizing Healthcare recordings there. Also, this session will be recorded as well, so you can find it afterwards, and you're very happy to share it after the fact with your colleagues and friends. Today, we will start with a summary of the challenges of cystic fibrosis by Professor Andres Floto. And then Mihaela will take over to talk about what work has already been done using machine learning. And then both of them will together talk about the joint work that is being done at the Cambridge Center for AI and Medicine before we go to the roundtable. At the end of the session, you will have the chance in a Q&A to ask questions to the panel and our speakers. If you have any questions at any point, please put them down in the chat, and then I will either read the question to the panel in the end, or Mihaela will do that, or we will just call you up and you can ask a question in person if you would like to do so. You should finish around 5:10. First of all, about the participants, next to Mihaela, who is our regular star of the show, we will have Professor Andres Floto, who is also co-director at CCAIM and Professor of Respiratory Biology at the University of Cambridge. We'll have Professor Damian Downey, who is clinical professor at the School of Medicine, Dentistry and Biomedical Science at Queen University Belfast. We have Dr. Jamie Duckis, who is a consultant respiratory physician and research lead for the All Wales Adult Cystic Fibrosis Service. We have Dr. Robert Gray, who's a senior clinical fellow and honorary consultant physician at the University of Edinburgh. We have Dr. Charles Haworth, who is a consultant physician at the Cambridge Center for Lung Infection at the Royal Papworth Hospital. Professor Alexander Horsley, who is professor of respiratory medicine at the University of Manchester. And Karlsen, who is the trustee at Asthma and Lung UK, and also non-executive director at Europe Assistance and the Museum of London Trading Board. So very happy to have this large number of experts today, and I'm really looking forward to the talk and the discussions. And we start with a presentation by Andres. So the floor is yours.
Thanks, Andreas. Welcome everyone to this session on cystic fibrosis and machine learning. To kick off this session, I thought it would be helpful to obviously introduce cystic fibrosis as a condition and motivate why machine learning methods might have a significant impact on delivery of care, hopefully with improvements in patient experience and opportunities to really refine the delivery of medicine. So as some of you will know, but I don't think all of you will know, cystic fibrosis is a really complicated and complex chronic disease. And over the last few years, I've been very fortunate to be able to work with Mihaela on applying her group's methods to cystic fibrosis, and indeed, they've developed a whole array of things that you'll hear about later. And this work has been supported by the Cystic Fibrosis Trust, and really thanks to Janet Allen, former CF Trust Director of Research, and Caroline, who was already mentioned, and very fortunate to be. We were fortunate to have her as a panel member, but she was an ex-trustee of in the CF Trust, and really drove these initiatives. And also thanks to Al Farrow and Preston Campbell from the CF Foundation for supporting these endeavours. Some of you may have heard me talk about our home monitoring machine learning applications in CF, which I'm not going to talk about now. And we're really focused on how we can use machine learning on electronic medical records to improve healthcare. So as I mentioned, CF is a multi-system disorder where thick secretions block and a number of different organ systems, including the lung, the liver, the pancreas, and the intestines, and lead to, in the case of the lungs, progressive lung damage as a result of luminal obstruction, impaired bacterial clearance, and chronic inflammation. But you can see that actually this disorder is genetically inherited. It's the most common life-limiting disorder in Caucasians, results in a number of different organ system involvements, and it is a lifelong condition needing really expert multidisciplinary care. While it's Mendelian in the sense that it's caused by mutations in the cystic fibrosis transmembrane regulator, CFTR, which is a chloride and bicarbonate transporter, it's very clear that that's not the only genetic contributors to disease. So really the motivations for implementing machine learning approaches are, as I've mentioned, that CF is a complex multi-system disease. It has complex genetics, so there's lots of CFTR mutations, over 2,000. There's also modulated genes which are unknown but clearly play a variable amount of effect in various organ systems. There is huge variable clinical trajectory even with people with the same CFTR mutation. And there's an array of different complications as a result of gene-gene interactions and gene-environment interactions. The variable individual response to treatment is really important, and that also includes the highly effective modulated therapy. And therefore, there's a real urgent need to improve clinical care, to find ways in which we can deliver the right treatment to the right person at the right time. We believe that solutions found through machine learning applications to CF should be generalizable to other chronic conditions, not only chronic lung diseases, but more generally. And so our kind of vision and our approach is to try and develop a deep causal understanding of CF and, trying to get to better understand this underlying structural causal model that defines cystic fibrosis, which is obscure. And you can see kind of various approaches depending on the kind of level of understanding, from associational questions such as, what are the symptoms associated with this, what features are associated with this condition, to questions around interventions. So what would happen if I do X or Y to somebody? To the counterfactual. So what if this person, instead of having done that, would have done that? And I guess the kind of levels of understanding of the underlying condition kind of involve deeper and deeper kind of understanding in order to answer these questions. So just to give you an example then, these potential impacts of machine learning start from the journey of an individual with CF. So based on mutations in CFTR or other mutations, present from birth, the acquisition of various infections in the lung, for example, complications such as diabetes and so forth over the span of a whole lifetime. And so we can try and think of opportunities for machine learning around understanding different competing risks, predicting future clinical trajectories, and predicting individual treatment responses. And this is a really nice summary from Mihaela's lab you may have seen last year or 2 years ago. So our approach has been to use National Patient Registry data, initially the CF Trust Registry data from 2008 to 2018, and supported by Janet and Becky and the CF Trust. I'll show you a little bit of data later on the CF Canada registry, and we hope very soon to be able to have a look at the US registry, which includes both annual and encounter-based data. And so then the key questions for us is, can we use machine learning to predict individual clinical trajectories and therefore potentially intervene appropriately? Can we leverage learning from CF in one country to another country, this kind of transfer of learning? Can we estimate individual treatment effects? This drug is good for this person and not for that person. Can we understand incorrect clinical decision-making, this idea of modifying how physicians or healthcare delivery people will think about problems and come to the correct conclusion? And then finally, can we integrate clinical and genomic data to better understand all of these factors? So I thought I'd show you what the UK CF registry data looks like. This is the age of the participants, which is kind of what we would expect from a CF cohort. And as expected, the complications of CF increase with age, as you can see here. The distribution and rates of complications with age are shown here. So you see a decline in FEV1, increasing rates of diabetes, of ABPA, death from lung transplantation, liver dysfunction, hearing loss, chronic Pseudomonas infection, osteoporosis, and depression. And so one of the first problems that we faced was, how do we deal with genotype information? So given the large number of genotypes, how can we incorporate CF genetics into the machine learning methods? And we came up with this solution, which we kind of consider as a template for how we might incorporate genomic information into machine learning methods. So this is ranking the likelihood of pancreatic insufficiency for individual genotypes paired with a known deleterious mutation. And we decided that this was a proxy for activity of CFTR, and therefore we were able to stratify individuals based on their CFTR dysfunction score, with 2 being the most deleterious and 0 being non-deleterious at all. And you can see quite nice correlations with pancreatic insufficiency as expected for diabetes, a little bit for liver cirrhosis, again, in keeping with other studies on the genetics. If you look at lung function doesn't correlate at all with CFTR dysfunction score. And again, this is in keeping with previously, and really implies that we need to find new methods in order to predict clinical trajectories. So I'll stop there and hand over to Mihaela.
Thank you so much first for joining us today. I'm really excited to be talking about cystic fibrosis, because this is one of the first area of medicine, one of the first diseases that I started to be engaged with when I started to do work on machine learning for healthcare. And I'd like to start by saying that I would not have started this endeavor if it was not for Janet Allen, who has had the vision that this could be possible. And she served as a tremendous inspiration for the work that we have been doing for 6 years now. Also, very much thanks to Karlsen, who was there together with Janet early on when we started to pursue this agenda. What I plan to do today is to move at a very fast pace to show to you what we have done in the past few years in this area. And I understand that some of the topics will be presented just very briefly, but if you are interested in, you can either refer to the publications, or me and my group would be absolutely delighted to answer subsequent questions. Already, Andres has shown this about the potential of machine learning and the piece that we have written a few years back. But what I hope to show to you is that much more is possible. However, I also like to preface this with a slide that I have often shown in Revolutionizing Healthcare. What you will see today is the beginning of the journey. I have outlined in a previous Revolutionizing Healthcare this pathway to reality. We need to with defining the clinical problem together with experts, modeling the problem correctly and mapping it to machine learning algorithms and solutions, validating it, internally, externally, in other types of data sets. Building demonstrators that allow clinicians like you to review, debug, test, and evaluate. And when all of that is really done, the real world begins, and taking these methods to reality, which may require productization by companies, which goes beyond what my own research lab and even our Cambridge Center for AI and Medicine can do. I'd like to say that through this journey with CF, I'd like again to thank very much to Janet primarily, but also to wonderful clinicians that were involved with us, Andres, Thomas, and also Oli Reiner, who has guided me through this work in modeling correctly and thinking about the problems that we were trying to solve. What I'm going to show to you today is a few methods that we have modeled with the help of our collaborators and validated. We are at this current stage now, so we thought that having this session will be important because before we move to the more complex task of building very complex demonstrators that could be truly encapsulated in clinical practice, is a good time to pause and ask for feedback. Here is the sheer extent of what we have done so far. I'm going to, in a very rapid progression, bring you through all of that. So please kindly bear with me. I'm going to, and I also like to extend additional thanks besides Janet to Becky, because it is due to their hard work and leadership in the UK CF registry that this work was done. So all the work you are seeing here is based on the UK Cystic Fibrosis registry. And again, you are going to see that a lot of this work has been published in our top machine learning venues, but the translation to the clinical setting is still to come, as I mentioned. And we have a website dedicated to these projects. It is not completely up to date, but it contains the majority of the projects I'm going to describe. And I also want to say that while today I'm mainly going to talk about bespoke medicine, and you may be familiar with this framework if you are part of our Revolutionizing Healthcare sessions, I'm mainly going to focus on bespoke medicine, but a lot, of course, can be done in terms of empowering healthcare professionals using machine learning, population health for better, let's say, screening and monitoring programs, as well as system pathways and processes, because collecting and curating high-quality, complex clinical data can also be empowered by machine learning through new ideas from data-centric AI. But let me return to bespoke medicine and what we can achieve. I'm going to start with the simplest of them, personalized risk prediction. And I'd like to highlight that there are many possible personalized prediction problems: predicting survival, time to event analysis of all different types of complications, predicting lung function, and predicting different types of infections occurring. And the challenge here is, shall we really develop a new model, a new machine learning model for every of these prediction problems? And shall we update the model every time you are collecting new data? Even worse, if practice is changing, shall everything be changed? How to do that? Another challenge is the fact that the area of machine learning is complex. Machine learning is quite complicated and requires a lot of expertise. So building this type of pipelines that deal with both data curation, data imputation, selection of features, and building the machine learning prognostic scores require quite a lot of machine learning expertise that may not be available to most people. So what we envisioned quite early on in this agenda, given the complexity of these clinical data and methodology challenges, was to develop this automated machine learning concept where we take data and at the push of a button, we are creating prognostic scores and explanations about that. The focus is not to replace clinicians. The focus is to replace the data scientists, analysts, machine learners, and statisticians in the process of solving this simple task of simple yet complicated task of building prognostic scores. What remains as a challenge and will always be important for that the clinicians and patients are involved is the modeling choices. So here is where a lot of insights and knowledge from the clinicians will always remain and will never be automated. But then as soon as these modeling choices are done, automated machine learning can provide the prognostic scores and the explanations. And then the model interpretation and debugging can be done again by clinicians and possibly patients. As a matter of fact, the next Revolutionizing Healthcare, we are going to go back to this paradigm. So if you are interested, you can come to the next session as well. And indeed, early in 2018, we built a tool for crafting clinical scores. We call this tool autoprognosis. It is able at the push of a button to build prognostic scores. And one of the first diseases actually that took this automated machine learning framework to cystic fibrosis. Since then, we have validated in more than 20 different diseases. But one of the first ones was cystic fibrosis. And what we looked at was really which patients should get a lung transplant and when. And we knew that simple FEV-based criteria were often used to make this important yet complicated decision. And we wondered whether we can do better with data-driven machine learning models. For that, again, we have used data from the Cystic Fibrosis Trust, and we aimed at predicting mortality, and again, trying to use that to determine whether a referral to a lung transplant should be done. We also compared it against a variety of methods that are purely based on FEV1 predicted, as well as models validated in the UK CF registry or the French CF registry. You see here two examples, the CF-ABLE UK and the model based on the French cohort. And you see that they are relatively simplistic methods which are based on some simple scoring system. What you see here is that autoprognosis is significantly outperforming all these different types of scores. And this is true not only for area under receiver operating curve, which I would beg to say, and you can read more about it, is not the right metric to consider, but rather precision recall is what's important when you are determining the decision of transplantation. And what you can see is that the risk score proposed in France offers a quite decent AUC, but really does not provide any gain in positive predictive value compared to even the basic FEV1 criteria. And the story we see at CF-ABLE UK was even worse because there the performance was much worse even than FEV1 criteria. So this shows the importance of moving to data-driven methods to solve these problems. And you see here a simple example where we, at a fixed NPV of 95, you see the comparison against these scores. Now, what's maybe even more exciting, and here where we benefited from the expertise of both Thomas Daniels as well as Andres Flotto, was that our analysis, which was done without clinicians, was able to provide this analysis of the biggest contributors. And then together with Tom and Andres, we have looked at those contributions, and they found it exciting that one of the biggest predictors for degradation was oxygen therapy, as opposed to FEV1 or other markers. And we have built and outlined in that paper interpreter that is capable to show how patients, depending on their covariates at the personalized level, fit into the different risk categories. Let me now move to what Andres called the longitudinal trajectories of disease, the personalization of longitudinal trajectories of disease, where potentially we may have different risks and competing risks over time, as well as the need may occur of personalizing the monitoring of patients. And again, we need to move from this cross-sectional modeling, simple prognostic modeling based on cross-sectional data, to longitudinal modeling. And that's the wonderful thing about both electronic health records as well as powerful disease registries like the ones that exist in various countries for cystic fibrosis. The power of having such a longitudinal trajectory for understanding a complex disease such as CF is tremendous. So we need to utilize that judiciously. You see here, for instance, an example of an electronic health record, but similarly, you can have this information from the registry, which is maybe similar in nature, but maybe at a coarser granularity. And you see that we have biomarkers, diagnosis, treatments, and symptoms, as well as the time at which the patient have visited. You also see different types of comorbidities occurring or appearing in the record of the patient at different times in the form of these ICD codes. And this is now a more challenging machine learning problem because we need to learn on the basis of such observational data that contains both longitudinal biomarkers such as FEV1, but also comorbidities and interventions. And given all that, we need to make projections into the future. Interestingly, from a machine learning point of view, and complicated as well, is the fact that, as Andres mentioned, CF is a very complex disease. And there are this interlace of factors that make prediction a lot more challenging than in any other type of medical data that I personally dealt with. So this represented really a challenge for us, the machine learners. In the first work we have embarked on this, we have decided to model these different types of complications as well as biomarkers jointly to issue predictions of different types of biomarkers like FEV1, but also different types of complications or comorbidities. And for that, we built a deep learning model that is based on a recurrent neural network, which is similar to the one that's used in language translation models, because also in language translation models, we have time series models. But here the time series is, of course, a lot more complex, are these different biomarkers and information from the record of the patient. And also, unlike in a language translation model, in this case, we have many things we would like to predict. So this is what we call a multitask prediction problem. So we needed to really come up with an innovation in terms of machine learning to address this competing risk prediction over time, these multiple risk predictions, biomarker prediction, as well as different events of interest. And this model, which we built quite some years ago now, we compared it with more vanilla methods for deep learning, as well as with joint models and landmarking, which are often used in the biostatistic community. And we show the power of deep learning in general and our model in particular. Also, we not only predicted, let's say, survival, but more interestingly, we also predicted, as I mentioned, these many different types of comorbidities, infections, as well as biomarkers. And again, you can see here the superiority of our machine learning model that's shown on top, as opposed to the joint model, which was the best biostatistical model. And you can see that the performance is significantly better due to the ability of these machine learning models to deal with complex information over time. But what about time to event? What I showed to you before is mainly focusing on predicting within a certain time horizon, 1 year, 2 years, 5 years, at a predetermined time, the events. But what we would also like to know is how the probability of a particular event of interest is changing over time. We don't want to know whether it will happen or not and at what value, but also how this probability is changing, because that may affect care. So in a subsequent work, we started to do time to event analysis based on these longitudinal trajectories. And we have done that as well as trying to understand how these different risks may change over time as the trajectory of the patient is changing. And what you see in here is an example taken from our work where we are showing how predictions of different types, FEV1, hospitalization, etc., are changing for different classes of patients, and trying to understand what variables that are static and what change in the dynamic variables is going to be the most predictive for this future evolution of risks. But if you think about this longitudinal prediction agenda, there are two goals. One is the one I just described, of predicting individualized level disease trajectories. But an equally important thing is to empower the clinical researchers, the clinicians that are researchers as well, to understand the disease progression mechanism, to truly understand underlying latent structure of disease evolution, causal pathways, as Andres has mentioned earlier, subgroups that evolve potentially differently. And finally, if we are able to do that, we are able to do early diagnosis of events, which may be beneficial because then we may know how to treat, and when to stop treatment. So how can we detect disease early? Again, if you are part of our Revolutionizing Healthcare community and you have been in past sessions, you have seen that when, for instance, I talk about cancer and early detection of cancer, I have introduced this idea of a state and a progression within states. But these states are not necessarily the stages of cancer. This is not about staging when cancer has already occurred. We have introduced a much more general concept of a state and disease progression across states that can be used for any disease, not only cancer and not only as measured by pathology. Instead, the clinical observations associated with the different states of disease are as shown in here. Some may be predetermined due to genetic factors, but then there may be early indicators of disease, non-specific symptoms, all the way to specific symptoms. And all of that are information that we can use to unravel and infer the hidden state of patient disease. So with this idea of state and stages of disease, we have a quantitative understanding of disease progression, where we can tell how many states of disease exist for cystic fibrosis. Does everyone passes through all these stages? Are people transiting much faster to a new state, while others remain in a better state for a much longer period of time? And we have built for that a method, another machine learning method that blends statistics and machine learning together to enable this state-based modeling of disease for CF. And you see here 3 stages of disease, and associated with this, different types of comorbidities that are occurring, and more about that can be found in this very preliminary paper from a medical point of view, but very thorough paper from a machine learning point of view. And we also show there that these stages and states could depend on static information such as gender or different mutations. And indeed, with these methods, not only we can better understand and predict early disease, but also we were able to have improved performance as opposed to other statistical or machine learning methods, inclusively our own work. Another interesting agenda is that of clustering. And here what I'm going to talk about is temporal clustering. Very often when we think about clustering in the longitudinal setting or static setting, we think about similar patterns. So in the longitudinal setting, this would be similarly evolving patients. But what we saw in cystic fibrosis as well as other diseases is that just having similar patterns doesn't mean that people will have similar outcomes. Just the fact that 2 patients have similar FEVs over time doesn't mean that they are going to have the same complications over time and possibly at the same moment in time. So introduced, motivated by this, a new notion of phenotyping or clustering that we call outcome-driven clustering, which we feel it's important for doctors and patients because what is important is not who is similar to each other in terms of biomarkers, but who is similar with each other in terms of comorbidities and events of interest. And again, we are learning from the past to predict clusters for the future. And this is again a very brief schematic of this temporal phenotyping work that we have developed a few years back. And Andres will tell you more about how now we are taking it to reality in cystic fibrosis. In the original paper, we have only a proof of concept. And what's interesting is some of you may have heard about AlphaGo and methods that for reinforcement learning that Google DeepMind has done to play all sorts of games. We have taken the same reinforcement learning idea and applied it to something, in my opinion, more useful, learning these different types of phenotypes. So it is this AlphaGo type technology that we have used here to learn to not to learn the game of Go, but to learn the complex game of disease trajectories and predict what will happen in terms of outcomes. And you see here different clusters, and they are changing over time. If you want to read, to listen more about this concept of temporal phenotyping, we invite you to look at a session that we have had with several clinicians in October 2021, which was really dedicated to temporal phenotyping. Finally, I just would like to say that one more thing that's important is treatments. Andres already talked about interventions, and then the most important thing on the causal ladder being counterfactuals. What would have happened if we were treating these patients at a different moment in time, differently, with different sets of treatments, or we would stop treatment. So this is what you see in this portrait in here. We may have information about patients. And what we are doing is we do this causal inference, where we are learning on the basis of this longitudinal electronic health record data, trajectories of disease, as well as different types of outcomes and counterfactual outcomes as well. So what would have happened if you would have treated patients differently? We can then answer questions such as what type of treatment plans we should give, what's the optimal time to start or stop a treatment, and all of that can be learned from observational data. Again, we have had in September last year a session on exactly this topic of learning personalized treatment effects over time. It was applied to ICU, but similar work we have done actually in cystic fibrosis. So in a package that we have built, a machine learning package that we have built called Clairvoyance, which is an automated machine learning framework that does personalized prediction, personalized treatment planning, and personalized monitoring, we also consider these types of counterfactuals in a toy example, proof of concept for cystic fibrosis. Finally, the issue of clinical trials is an important one because often different types of trials may be very difficult to do in the cystic fibrosis population that is so complex and so diverse. So as an alternative to that, we have built some new technology that can transform really clinical trials. And for that, I invite you to take a look at our last 2 clinical trial sessions in the Revolutionizing Healthcare stream, which we just have had before the break. And with this being said, I'd like to go back to Andres to say a few words about what we have done together since.
Okay, so just to give you an idea about how good the RNN approaches are to predict future outcomes in CF, this is an example of the predicted versus the observed for lung function, but you can do this across all complications. This is work that has been driven by Chang Ki in Mihaela's group. And again, as part of other methods that developed by the Schaar Lab, you've been able to look at the overall feature importance of things that are used in order to give the prediction. And in fact, you can estimate these on an individual person's basis and then group people into different, well, you can cluster people into different groups depending on which features are important for their prediction. So that's really really mind-blowing and potentially reveals underlying processes that are different in individual patients. So as Mihaela mentioned, the method developed by Chang Ki and here implemented with help from Timing is this outcome-oriented clustering. So basically the question is, can we group patients together that have the same longitudinal trajectory leading to a specific outcome, in this case, respiratory failure? And the answer is you can very clearly distinguish 3 different phenotypic groups in CF, 1, 2, and 3, mild, moderate, and severe. They have overlapping clinical features at time 0, that's to say when you see them in the clinic, in terms of age, BMI, HbA1c, lung function's a little bit different for the mildest group, and obviously some complications are more common in the more severe groups. But actually, this is really important. So the machine learning methods have defined accurately the long-term prognostic trajectories for these individuals, which would have been obscure to clinicians. And then you can plot individual patient journeys as they grow older, from the mild to the moderate to the severe risk groups. And in fact, these correlate to different outcomes. This is survival Kaplan-Meier curves. But I think this is kind of a really interesting concept. And then you can see here as an example on an individual patient basis, this is mild phenotypic group, so low risk phenotypic group. Something happens at this point here, they go into the medium risk, and then something happens here, you go into a high risk. And you can see how actually a lot of things are not changing necessarily over this time. You can see the risk here in red, the FEV1 predicted in blue, and the IV antibiotic treatments in green. But nevertheless, the model is able to sense that there's been a change in risk, which presumably would, if implemented, allow perhaps more investigation or more or changes in therapy. And one of the other things you can do with these kind of models is to say, right, well, if I were to change one of the features from being present to not being present, how would that affect this transition from mild group to moderate group, or moderate group to severe group? And you can begin to kind of generate hypotheses about things that might be important. And one of those was hypertonic saline. So those individuals intolerant of hypertonic saline are more likely to go from the mild group to the moderate group. And in fact, if you stratify by being intolerant or tolerant to hypertonic saline, you see differences in outcome. It's kind of interesting, and again raises a lot of interesting questions. And similarly here with mast cell stabilizers, which we don't really consider as a mainstay of treatment for CF, again, if you were to permute that to being present, then you see a lot more people will move from the high group to the low group. And interestingly, if you look at lung function here, stratified by whether you're on mast cell stabilizers or not, there's a difference, a significant difference. And obviously these are associations rather than causal, but again, generating really interesting hypotheses. So finally, in the last minute or so, just to give you an example of how we can use, in this case, another AutoML method from Mihaela's group, generated by Yu Chao, to compare the UK and the Canadian CF registries. So this is a model that's been developed to predict the risk of death or transplantation, and then you can directly compare you can train it on the UK and apply it to the Canadian, and then train it on the Canadian and apply it to the UK, and actually see very different drivers for this target outcome. And again, indicating or suggesting that policy changes may impact significantly on survival and or transplantation. So in summary then, I think there are enormous potential impacts of machine learning in CF. Decision support, what is the best thing to be done? Cognitive support, this idea of training physicians to make better decisions. Some causal understanding, which gives biological and scientific insight, and optimizing management, as Mihaela says, who, when, how, and to treat, and indeed to monitor. So the opportunities will be enormously increased with larger data sets. We're very excited at the prospect of looking at the CFF US data sets. Incorporating encounter-based as well as annual records will obviously give us a level of granularity which is bound to really enhance what we can do. And then so my pet hope is that we can integrate the home monitoring data that we've been collecting into these machine learning methods, and indeed adding genomic data from our own NIHR bioresource that's occurring here, our genomics, and obviously the genomic data that may be available elsewhere. And finally, and clearly this is a CF specific talk, but you can imagine how easily these methods might be generalizable to other medical conditions. And I'll stop there.
So maybe I can take it away. I have prepared a few questions from my world, the machine learning world, to you, the clinical world, to all the panelists, including Andres. So do you think that some of the presented machine learning tools, if productized, would be useful for you and your patients? And which ones do you think would be more useful, and hence we need to spend more time demonstrating, debugging together with you and the community? And which ones do you believe are less useful, and why? Andres, I will ask you to maybe help me prompt the question to the various panelists, if you can help me, please.
Yes, of course. Let me pick on someone. Okay. Thank you. Charlie, why don't you take it away?
Well, I mean, many of the applications could be hugely useful to patients and clinicians. I mean, I guess the timing of transplant referral is really interesting, and clearly one would think first perhaps about lung transplant prediction, but actually, you know, many of the other transplant decision-making could be enhanced. For example, when might someone require a renal transplant, and what could you change to delay the requirement for a transplant? And, you know, I'm thinking of patients with poor diabetes control, patients that receive renal toxic antibiotics. Can one model and predict that if you did this, this would extend your kidney survival for this period of time? And those sorts of things would be really empowering, I would have thought, for specific patients.
Great. Alex?
Thanks, Mihaela. Thanks, Andres. And yeah, there's different questions here. There's how we use the data we've got to understand the population as it stands, and then there's how you predict for individual patients. And I think the latter question will probably depend a lot more on the complex data you can get in from home monitoring, and, you know, Andres, from genomics would be fantastic, wouldn't it? But that's from, you know, from repeated measurements of the same biomarker longitudinally. But if we talk about the data you've got at the moment, I mean, it's perhaps not directly answering your question, Mihaela, but in terms of applications that I can see for what you've got at the moment, and there are other biomarkers that we now measure routinely, like sweat chloride, and we know that our patients have got much better CFTR function than they had, and we don't really know what that will lead to in terms of their long-term trajectory. But we do have patients who have well-preserved sweat chloride, and we could, you know, you could make inferences, I guess, from trajectories of other patients about how our new patients will respond, and also then following them over time to see what impact that actually has, because it's something we actually measure on all our patients now. So I'll pause and let someone else speak.
Alex, I just wanted, apologies to intervene. In the Cystic Fibrosis Trust in the UK, we do have repeat measurements. It's true they are not very regular. It's only every year.
Yeah.
But this is interesting. Even that is useful for some predictions. And like you rightly say, maybe less important for other predictions. But what's interesting, I think, with machine learning is dumb. It's not smart. So numbers matter. The more data we have, the more patients we have, the better we can do. And hence, maybe one could look at the value of the different data we already have to issue the predictions of interest. And these automated machine learning tools could answer for you, the clinician researchers, maybe some of these questions about the value of the data that already the CF trusts have. Sorry for the interjection.
No, absolutely. No, I realize that the CF trust data is absolutely longitudinal, but it's quite sporadic. It's not the same as having real granular data on an individual. But you could use that, for example, if talking about trajectory of current patients who are now modulated, you'll be able to look at patients who've got well-preserved CFTR mutations, so well-preserved CFTR function, well-preserved sweat chloride, and try and infer trajectory of current modulated patients from what's happened previously.
I mean, Alex, there's two questions there, I think, isn't there? There's predicting the response to the modulated therapy.
Yes, that's separate. Yeah,
very interesting, and you can see from the phase 3 data, as Janet's just posted here, the waterfall plot is really striking. Real variation across there. So the response to this modulated therapy and potentially others in the future, and the second is the impact longitudinally in terms of everything else, right? So so having got on the modulated therapy, what is the response, and then are you likely to respond? So that's really interesting. Let me hand over to Robert.
Yeah, hi. Thanks, Andres and Mihaela. I'd maybe like to turn it on its head and say not what's useful to us as researchers, but what might be useful to the person living with CF, and how we can use this tool. Because the thing that struck me was your use of the counterfactual estimation. Counterfactual is usually a word I sort of associate with political journalists talking about what ifs, but actually it's really useful from a CF perspective. If we could use a patient's data to inform them what would happen if they took drug A, what would happen if they didn't take drug A, what would happen if they had frequent exacerbations. So for me, that's where I see the true power, actually handing back power to the patients to make their own decisions based on the best available data. And I know that's taking us slightly off course, but that was the thing that came across to me most strongly during everything we've seen so far.
Robert, you're absolutely right. I mean, the motivation behind all of this is not anything else other than in supporting individuals with CF.
That was my question number 3 or 4. What AI can be built for patients? So you already have stolen that question.
No, but I think that's absolutely that's a totally important thing. And also, I guess the other thing is around, the frequency of monitoring, which as people become better, this kind of active sensing, as Mihaela would say, understanding when it would be most appropriate to monitor. Caroline.
Yeah, I mean, just to say what Robert just said is absolutely spot on. Being able to say to a patient, or hearing as a patient or as a carer of a patient from a doctor, if you do X or if you do Y, the outcome is going to be such and such, would be, I mean, transformational. The other thing that I think would be incredibly helpful, and I know, Mihaela, you are working on that as part of this project, is for a patient or a carer to know that an exacerbation is on the way before they're actually aware of it, is again incredibly powerful, because you can then do the sort of things you would do as a non-CF person when you think you have a cold coming, stop exercising, take more vitamins, get more sleep, that sort of thing, which can prevent or at least lighten an exacerbation if it turns into something really nasty, or you start taking antibiotics preemptively. And it's that sort of thing that really empowers the patient or the carer to take control of their condition, rather than having to wait for a doctor to say, well, now you've got really bad exacerbation, here's some antibiotics.
Thank you, Caroline. And Jamie?
Yeah, I was very much about the co-design of it, and my immediate reaction is about shared decision making. So exactly that. So for example, one of our interests is about predicting what will happen when people become pregnant, for example. And so for rare diseases, you don't know what's going to happen to their lung function. And I just wondered about capturing quality of life as well. So lots of the registries will have quality of life, and that might be quite an interesting one. And then the other thing I was wondering about, certainly in Wales, we're very lucky to have the SAIL data bank, which is all primary care records as well, and A&E contacts, and that would be something really nice to But yeah, as regards to other conditions, that the renal thing, even outside CF, that would be a really interesting thing, isn't it? It's an area where you've got registry data, you've got lots of recurrent readings, and you've got lots of decisions about when to dialyse, what mode of dialysis, do you dialyse at home? There's so many things. And then when do you go on to a transplant? So I guess it's picking areas where there's lots of data and lots of decisions that are made, obviously, in conjunction with people with lived experience. So it's giving them that ability to track, and in conditions where there's not lots of evidence, pulling as much evidence as possible and making it really pertinent to that individual.
Great, thank you, Jamie.
So what do you consider the major challenges going forward in the next 5 years, given the fact that there are so many new drugs and treatments, and the realm of CF has changed so much in the few years that at least I've been involved with it? Can AI help create some new tools that can improve this clinical decision-making for the new challenges? I think some of them have been discussed, but if any of you would like maybe to point out anything additional, please unmute yourself and maybe answer that.
I guess the really exciting development is clearly the development of the CFTR modulators. And one of the questions that we get asked almost in every clinic consultation is, what medicines can I now stop? Or can I reduce the frequency of my airway clearance? Can I replace airway clearance with exercise? And so to be able to potentially guide patients would be immensely helpful.
And can I stop going to clinic, for example?
That too.
Yeah. So I totally agree. How often do I need bloods? How often do I need a liver ultrasound? How often do, those are really, really super important questions.
Could I just add one thing to that? Sorry, it's really about one of the challenges that I see. We do pretty arbitrary things with antibiotic treatment for exacerbation. Can we use this technique to look at a way of finding out, do we need to use as many antibiotics? Can we use a shorter course? Can we use oral antibiotics as opposed to IV antibiotics? So trying to start looking at those questions, because we've really, in the past just said, right, you're sick, you get 2 weeks, you're not getting better, you get 3 weeks. Could we be giving 5 days of oral antibiotics for an exacerbation if we catch it at the right time? So for me, that would be really powerful. Again, it gets back to making our patients' life simpler as well by simplifying treatments.
So Robert, you're absolutely right. Charlie was talking about individual treatment effects, and then you were talking about counterfactuals and whether you could use counterfactual information to guide change.
Even more than that, I think, Andres, I think Robert points, if you like, even at the most complex of counterfactual questions, because it's what combination, the combinatorial aspect of it, and potential dose. Let me just answer a little bit. I want to say that many of the things you are talking about here, some of them related to monitoring, some of them related to biomarkers, I think the technology is somewhat there. It's now up to you making alliances with machine learning researchers like me and others interested in this area to now start to put these questions, because with the machine learning researchers do not know medicine. So as I mentioned, it's now time to kind of ask you to join forces with us to look at the different questions you put. And I think for many of them, the technology is now somewhat ready to be debugged by you and with you. But Robert, what you mentioned is probably one of the most complex things I've encountered. And Janet often mentioned related things to me. And again, I'm going to repeat, machine learning is dumb. So we really need quite some data to answer these complex questions. What combinations of treatment, what dose potentially, what length. So I think we need better data. We really need the different countries, as Andres has mentioned, the UK, US, Canada, France, anyone who has such beautiful data sets to kind of join forces to look at this together. Granted, this will bring new challenges for machine learning because the populations and standard of care are different. But even with these challenges, would be preferable to have more data sets such that we learn from these differences, including the differences in care that may exist in different countries. So maybe we use this as a call for action, both for you, the clinicians, to engage with machine learners like us, to tap into the simpler problems you mentioned, monitoring, predictions, risks, longitudinal trajectories, and then maybe a call to everyone who may be on the call or can reach out to people who have such data sets in other countries to pull this data through different types of methods like federated learning or other methods, such that we can really share this data somewhat with confidentiality, of course, in place, to be able to really build these models across these populations, because machine learning, as I mentioned again, is dumb. So it needs to learn from patterns that it sees smart doctors in different countries doing. And maybe even by patients, smart patients deciding to stop and good things happening to them. I don't know whether this is the case. So it's really, what can we do for patients in general and clinicians to move this agenda forward? What recommendation you have, especially to us, the machine learning community, to empower you and the patients?
Well, I mean, I think you've touched on the main question, isn't it? Which is, how do you rationalize treatments? How do you deliver the amount of treatment you need, but not too much? And that treatment in that sense is monitoring as well. And you know, you talk about liver ultrasounds. We do them every few years, but really we know even now that they tend not to progress once people are in adulthood. But if you were able to collect data on a more individual level and feed that in as well, you'd have knowledge of how long a course of treatment a patient is taking, regardless of what you prescribe them. You'd have knowledge of whether they're actually doing the nebulizers, and then you'd be able to see whether, on a population basis, whether that made a difference. That's sort of an extension, if you like, of a real world trial.
Caroline, any thoughts on this particular question?
I think it's sort of what we said earlier, giving both the patients and the carers, as well as the clinicians, the tools to make the right decisions at the right time, individualized to that specific person, as opposed to the way it is now, which we just said, you have an ultrasound once a year, get a sniffle, you get 2 weeks of antibiotics, and that may or may not be the right way forward, but it's a one-size-fits-all approach. And therefore, for many people, it's not the right approach by definition. So I think that's where this is really, really powerful.
Thank you. Any more thoughts?
I was going to say, I think, Mihaela, it would be really important to do, you asked about reaching people, to do focus groups, because the other thing is that some people with CF may not want to know. So there may be some data and outcomes that people don't want to know. I know when they've previously looked at insurance and how long people might live, etc. So there may be bits of data that people are not interested. On the other hand, there'll be bits of data that would be really useful to know. And the other area, I think, maybe I'm second guessing, is the adherence. Certainly we had a meeting today with the new modulators. Some of the pediatric population coming through may not have ever been very unwell. So they may not have sort of experienced what we see in adult physicians in CF. And so then their beliefs about how necessary taking the medications are change. And so giving them some information about what may be a trajectory with or without an adherence might be really useful. But I'd really say it's really important to gauge what they want to know, what areas would be really important for them to predict, if that makes sense.
Jamie, that is very interesting, and I think it will be fantastic work to be doing together with clinicians that are interested in this. Let me again also say that we with the machine learning community, need your guidance, not only as to the right problems and the right data to use to solve the right problems, but also to sensitive issues like the one you mentioned that the patients may not want to know. Again, to some extent, we need your guidance as to what is the right pertinent question and how to publish these results in a way that's sensitive. That's the reason some of this work has been published more as a toy example, and at times with not complete analysis, complete report of all the variables, partially with that, but we need your guidance.
Could I just add one last thing? I think from my perspective, removing the fear of AI is probably, and machine learning is quite important. In terms of most doctors don't know how it potentially works. A lot of doctors would feel they will always make a better decision than a learning algorithm. And a lot of people with CF might not understand what the process is either. And I think to engage the community, you know, we have to speak to those people. I think the fact that you say that machine learning is dumb is a great message, because everybody's worried that machine learning, or a lot of people's perception would be this machine learning will come out with a decision that is, you know, it's bad, but actually they will use the same information that we use and probably have less bias and less unconscious bias in that decision making. So I think getting that across to the community, whether it be doctors, patients, carers, and engaging early on is probably a good way forward, and in many ways echoing what Jamie said.
Thank you, Robert. To be honest, this is why we started these engagement sessions, Revolutionizing Healthcare, to start to discuss with clinicians from all over the world about these issues and provide more information about machine learning. But what is, I think, the next stage as machine learning is starting to mature, to actually engage the clinical community, to engage with these methods, debug them, and see them as tools. I often make this analogy. You would not like to go into a plane where there is no pilot, and you would not like to go into a plane where there are no tools to support the pilot. Especially with a complex disease such as CF, having the right pilot, meaning the right clinician, equipped with the right tools seems to me the best combination. And this is what we are trying to advocate. But of course, to get there, we need the clinical community and pioneers like you to engage with these tools, shape them such that we solve the right problems and we debug them adequately. So thank you very much to all of you for actually joining us today in this discussion. We ran a little over time because I was a little bit too enthusiastic in presenting to you the journey, but it is really CF that has motivated my work more than any other disease. And it is due to this complexity and due to all these challenges. And I want to thank you. I want to thank all the community for really engaging with us and bearing with us. And now hopefully we can return back something to you. We are keen to now go to the next level and build for some of these technologies together with whoever is interested, demonstrators, because you cannot engage with these methods. It will be absurd. Like I cannot engage with the medicine. So now I would say the next level is building demonstrators for the different things we discussed. If you are interested, please reach out, building these demonstrators, debugging these ideas, and that will bring us one step further to making these tools really available to clinicians and patients.
Hi, Andres, can you hear me?
Yeah,
yes.
we can. Yeah.
Yeah, no, it was a question, and you've sort of addressed, but I guess it goes back to Mihaela, your point, which is machine learning being dumb. And so the quality of the data from which you work is essential. And right now, in Western countries, in North America, and Canada, and Australia, Europe, there is access for those who are eligible for these wonderful, highly effective modulators that are truly changing the landscape. I mean, we're doing in the US about 15% of the lung transplants that we did just 2 years ago. It's been rather remarkable, the impact in even those who have advanced lung disease. So taking that into account, we really don't have longer term data for those on highly effective modulators, especially outcomes data. So that I would perceive that's a challenge for machine learning. And so how do you address that challenge?
This is exactly the type of counterfactuals to something. So your question had two parts. One is the role of data, the quality of data, the biases of data, the errors in the data. Increasingly, we are building machine learning tools to improve data curation and data quality. That's the beginning part. But then trying to see the impact of these new medications that you are talking about on outcomes and look at these counterfactuals is exactly the type of tools we have been building that we call these counterfactual estimation methods, where we are saying, if I would have given this treatment at a different moment in time, or if I would have given this treatment to this person at this moment in time, will I be able to do without this other intervention, which in this case is transplant?
Ivacaftor has been around for much longer. It's been around for 10 years, certainly in Europe and probably longer in the States. Can we learn from ivacaftor and project forward to what would happen with the new drugs, or is that completely off the wall?
I guess we could look at ivacaftor and look at the effects of ivacaftor before or after its introduction. With any such problem, we need some of you, the clinical community, to engage with us to make sure that we answer the question correctly on the basis of the correct data and the findings are indeed correct. But the methodology is in place to answer such questions if someone is interested in pursuing it.
Yeah.
Yeah, I think, Jan, I think the challenge, as I pointed out in my little chat, with ivacaftor would be the relatively small number of patients. I mean, you're really just looking at those who had gating mutations, right?
Yeah, I agree, Al. And one of the things I think I've bored everybody with ad nauseum is on the ivacaftor data. It's always concerned me that the control group is G508 del, and it's not really a valid control group. And the thing I've always been quite interested in is looking at the impact of the drug on the individual at the time. So looking at the trajectory pre and post ivacaftor, but I think I've bored Mihaela and Andres sufficiently. But
Janet, no, you raise a very important point, and I think this is an example of kind of transfer learning, right? So what can you estimate would be the impact on 508 del of a similar type of effect? So I think that
this is more complex, Andres, than transfer learning, because transfer learning, we often would say transfer from this to this population risk score, but here we talk about even different drugs altogether now with different.
It's for another day. For another day.
Thank you very much, everyone.
Yeah, thank you very much for the great discussion, and thank you very much for the questions as well. Thank you for this great session. Coming up next is our 20th anniversary, basically, Revolutionizing Healthcare session in October. And we will talk about machine learning for clinicians using the next generation of machine learning tools. So a very practical clinician-focused session once more. Today's session will be on YouTube over the next days. And I'm really looking forward to see you all back in October to see the next session. If you have any colleagues or other practicing clinician friends, please send them our way and have them subscribe to our newsletter, and then you will not miss anything new coming up. Thank you very much.